So I want to welcome everyone. I'm thrilled to see this UCSF community-wide turnout for a very important topic. I think it might be the first time that we've brought together this interdisciplinary group to talk about the opioid crisis and addiction medicine. And I want to welcome everyone to the 6th year of this quarterly social science speaker series organized by the Department of Anthropology, History, and Social Medicine in collaboration with Dean Catherine Lucy, who I can't thank enough, and the Office of Medical Education and her staff for being our partners in these events over 6 years. Tonight's lecture is also co-sponsored by the Department of Psychiatry. We're thrilled to bring together a panel of experts who will draw from their research, clinical experience, and anthropological experience to talk about addiction medicine and the opioid crisis. So the first thing, of course, I want to mention is that we live and work in a social context, and UCSF is a very broad community of players, and we all know what's happening outside, what started today, the strike, which will go on for 3 days. And I think it is not ironic that we're bringing up a topic in this forum to talk about issues of social justice and equality, the role of medicine, the role of ethnography, and we just need to be aware of what's going on in our total community, and I think everybody in this room is. So I'm going to introduce all 5 of the speakers and let them speak, and then we will open it up to audience back and forth and discussion. So I'm thrilled to invite our out-of-town guest, Dr. Helena Hansen, who holds an MD and PhD. She is a psychiatrist and medical anthropologist, associate professor of psychiatry and medical anthropology at NYU. She's the author of the recently published book, Addicted to Christ: Remaking Men in Puerto Rican Pentecostal Drug Ministries. In this remarkable book, she compares and contrasts ministry's logic of addiction and treatment with that of psychiatry, enabling us to rethink models of recovery. Tonight, she'll address the ways that racial and class politics surrounding white middle-class narcotics use have shaped the marketing, regulation, and demographic distribution of opioids, the symbolism of opioid addiction in the popular media, and resulting drug policies. In addition, everyone here is invited to stay after the panel. Helena would be delighted to speak with you about her book and her work and read to you if you'd like from the book. Kelly Knight, our second speaker, is Associate Professor of Medical Anthropology in the Department of Anthropology, History, and Social Medicine on campus. She's the author of the prize-winning book, Addicted, Pregnant, Poor. She's been a speaker in this series. In her book, she describes the everyday experience of addiction in women's lives and examines addicted pregnancy from medical, policy, and social science perspectives. Tonight, she'll present data from her long-term research conducted in obstetrics with pregnant women and with chronic non-cancer pain patients in primary care, emphasizing the relationship between clinical care and patients' structural vulnerabilities. Helena and Kelly will each speak for 15 minutes. They'll be followed by 3 outstanding UCSF faculty who will respond and offer their thoughts. In alphabetical order, Christina Mangurian, Professor of Psychiatry, Vice Chair for Diversity and Health Equity in the Department of Psychiatry. She's also Director of the UCSF Public Psychiatry Fellowships at Zuckerberg San Francisco General and core faculty in the UCSF Center for Vulnerable Populations at ZSFG. Next, we'll have Monica McLemore, Assistant Professor in Family Healthcare Nursing. She's a research scientist in advancing new standards in reproductive health and the Bixby Center for Global Reproductive Health. Her work in reproductive justice centers on the factors that influence health, well-being, and livelihood of low-income women and women of color. Finally, Scott Steiger, the Associate Clinical Professor in Medicine and Psychiatry. He's the Deputy Medical Director of the Opiate Treatment Outpatient Program at ZSFGH. They'll each speak for 10 minutes, then we'll open it up for the discussion. So please join me in welcoming our illustrious panel of speakers.
Thank you. How wonderful to be here, and thanks all of you for coming in at what is a really complicated time. I want to thank Sharon Kaufman and also Kelly Knight, whose brainchild I understand this is. Sharon working really hard behind the scenes to make this happen in the midst of a strike, and I think we should think carefully in the course of our discussion about inequalities and the relationship between the strike now and opioid overdose. I think there is a relationship. Forgive me if I speak quickly, because what I'm going to attempt to do is distill the major argument of my forthcoming book on race and opioids. I'm going to give you a snapshot of my multi-year study involving observations of drug policy and addiction science meetings, interactions in clinics, interviews with over 200 addiction scientists, treatment advocates, pharma executives, policymakers, administrators, prescribers, and patients. How's that? A study of the current opioid crisis as the product of the symbolic racial coding of pharmaceuticals on how opioids became white. And what I found is that disparities in opioid use and interventions are actively created by concerted yet hidden social technologies that are the key to the widely asked question. Here's my first slide. Why is the life expectancy of whites suddenly falling when the life expectancy of almost every other racial group is rising? And how did opioids become their primary immediate cause of excess death? My answer is different than the received wisdom that unemployed whites in the post-industrial Rust Belt turned to opioids for solace, for existential pain. So that might be true, but it begs the question, why white people, why opioids, and why now? So I'm going to argue that the current generation of opioids was designed to have white racial identities, and that in our stratified healthcare and justice systems, the biotechnologies and social technologies shaping opioid consumption reinforce racial inequalities through a two-tiered system of drug policy, while at the same time harming whites. So this is a story that I stumbled on by noticing the racial identity of an opioid used to treat opioid dependence, buprenorphine. So I actually came in on this as a medical student involved in the early clinical trials of buprenorphine, otherwise known as Suboxone, for opioid dependence. And noticing a difference between the racial patterning of buprenorphine, who gets it, with that of its predecessor, methadone, the only other opioid that can be legally used to treat opioid dependency in the US. So here's a bar graph from the first and last nationally representative study to compare buprenorphine patients with methadone patients by race and class. And my New York City maps of where people prescribe buprenorphine versus methadone live confirm these patterns. Note that buprenorphine and methadone are geographically the inverse of each other in New York City, and this is actually true in other parts of the country. But what we don't know from these graphs is, by what process have they gained their racial identities? So for methadone, let's go back to 1965. Race riots are burning through Harlem, Philadelphia, and Watts, Los Angeles. The unemployment rate for blacks is twice that of whites, and organized crime recruits a heroin sales force from black and Latino inner cities. So meanwhile, Rockefeller University diabetes researcher Vincent Dole, who thinks of heroin addiction as opiate receptor deficiency analogous to insulin deficiency in diabetes, published his findings from the first clinical trial of methadone maintenance among heroin-injecting African-American men in Harlem. And by 1970, President Nixon, who appoints pioneering methadone psychiatrist Jerome Jaffe as the nation's first drug czar, allows Jaffe to target inner-city blacks and Latinos as well as returning Vietnam veterans with methadone, the major weapon in Nixon's war on drugs. In order to prevent diversion and street sale of methadone, the DEA regulates methadone clinics, requiring daily observed dosing and regular urine testing, and locating clinics due to the racialized stigma surrounding methadone and community resistance on the basis of that, locating clinics in marginal neighborhoods in the city, remote from other medical services. Fast forward to October 8th, 2002. A new kind of opiate problem has developed following Purdue Pharmaceuticals' aggressive marketing of OxyContin as a quote-unquote minimally addictive pain reliever. Most of these newly addicted people are white, and many of them middle to upper income. The FDA has just approved the synthetic opiate buprenorphine, commercially packaged as Suboxone, for maintenance treatment of opiate dependence in private buprenorphine-certified doctors' offices. Pharmacologically similar to methadone in that it blocks opiate receptors in the brains of addicted patients, buprenorphine can be prescribed monthly for use at home, unlike methadone. This is the first time since the 1914 Harrison Act that generalist doctors are permitted to use opioids to treat opiate addiction. To accomplish this, the manufacturers of buprenorphine and the architects of buprenorphine policy almost 30 years after methadone had to distinguish buprenorphine symbolically and spatially from methadone. So buprenorphine pharmacologically in the same drug class as methadone had to be whitened. So this is Mike in an internet ad for Suboxone, seated in his Ohio diner, flanked by American flags, talking of his return to coaching his son's baseball team and singing in his church choir after buprenorphine rescued him from a prescription opioid habit following a back injury. So I invite you to think about the racial and class coding in this. But I argue that the ad was just the tip of the iceberg, that the whiteness of buprenorphine was actively achieved by specific social technologies. And I'm going to give you my analysis of the contemporary white opioid crisis in terms of what I call technologies of whiteness. That is, social technologies to maintain racial boundaries around biomedical uses of opioids. My scheme is informed by whiteness studies, an offshoot of critical race theory, which proposes that, number one, whiteness is a category of exclusion and therefore requires cultural and political maintenance of its boundaries. Number two, white race is unmarked as the assumed norm in the US. It's rarely explicitly named, either in public policies or in the media, with the exception of just after the last national election, actually. Number three, whiteness is defined by its other. Punitive, racialized drug policy has long had a mutually defining twin of legal narcotics for whites, including post-World War II barbiturates, Valium, otherwise known as suburban mother's little helper, and now back to prescription opioid pain relievers. White privilege has its costs. Not only do white consumers pay inflated prices for patented prescription opioids, they pay with their lives in overdose by legal substances to which they have, quote unquote, privileged access. So these concepts inform the four technologies of whiteness that I'm going to be describing in relation to opioids. The first is addiction neuroscience. So to understand the current opioid crisis, we have to place buprenorphine development on the background of President Bush I's Decade of the Brain. This was an era in which NIDA was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. Alan Leshner, who was then director of NIDA, National Institute on Drug Abuse, lobbied to rebrand addiction as, quote unquote, chronic relapsing brain disease. Leshner's ambition was shared by other leading NIDA researchers who co-authored a widely cited article in JAMA in 2000 with the title Drug Dependence, a Chronic Medical Illness, and in it they argued that narcotics addiction was comparable to diabetes, hypertension, and asthma in terms of heritability, treatment adherence, and relapse rates, and as such should be treated that way. So for instance, brain imaging like this, by taking out the subject and his or her trappings of gender, race, and class out of the frame and actually taking the offending organ out of its body altogether, the image symbolically conveys an unmarked universality of addiction physiology. And in neuroscience, addiction is further reduced to molecular action at neuroreceptors, the ultimate disembodiment of addiction. So the apparent universality of this molecular model implied an assumed white norm, erasing the social and racial foundations of drug use. This was a neurobiological version of colorblind ideology that some of you may have read about, for example, in Michelle Alexander's book. It consciously unmarked and whitened opioids by molecular means, paradoxically laying the ground for further racialization of drugs. The second technology of whiteness, new biotechnologies. Building on neuroscientists' erasure of the social from addiction in search of universal technologies, in 1996, Purdue Pharma got FDA approval for OxyContin as minimally addictive, an opioid pain reliever suitable for chronic management of moderate pain. And this was based on its patented sustained release capsule technology, which in theory lowered the reward for drug users by preventing an initial rush. Of course, what the model of addiction-proof biotechnology left out was the social inventiveness of drug use. So OxyContin users interested in a rush quickly learned to crush and snort or inject the contents of each capsule. And what followed has been called a public health disaster. A biotechnology developed in response to the resulting white suburban and rural prescription opioid epidemic is buprenorphine itself, commercially released in a combination pill with opioid antagonist naloxone and branded Suboxone. In the 1990s, NIDA subsidized Suboxone's manufacturer to test it for use in addiction treatment and sharply distinguished it from methadone, lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from narcotic Schedule II, where OxyContin and methadone fall, to narcotic Schedule III, along with common household products like codeine cough syrup. This is what made it possible to prescribe Suboxone in generalist doctors' offices. And in a race and class stratified healthcare system, as we have here in the US, where access to generalist doctors is often limited to those who can pay, patented technologies designed for private office delivery in themselves encode race and middle class. So the third technology of whiteness, regulation and legislating whiteness. OxyContin and Suboxone now have unprecedented monitoring and certification requirements for prescribers that stratify access to these opioids. Since suburban and rural whites were not politically supportable targets for law enforcement, the DEA and other regulators have focused their surveillance and enforcement on prescription opioid prescribers and suppliers instead. One sign of this has been the spread of prescription drug monitoring programs, which have been enacted in 49 states, half of which mandate prescriber participation with threats of loss of license and prosecution. Returning to buprenorphine, otherwise known as Suboxone, the Drug Addiction Treatment Act, DATA 2000, was passed by Congress to enable any certified physician to prescribe Suboxone in the privacy of their own offices. In congressional debates leading to passage of DATA 2000, there's a clear emphasis on a quote-unquote new kind of user, a young, suburban, and quote-unquote not hardcore, implicitly white person. Alan Leshner, who was then director of NIDA, testified that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to concentrate in urban areas and is a poor fit for the suburban spread of narcotic addiction, unquote. In the same congressional hearing, then Health and Human Services Director Donna Shalala notes that buprenorphine, as an alternative to methadone, would serve a new kind of addicted person, quote, including citizens who would not normally be associated with the term addiction, unquote. Again, this coded racial language. DATA 2000 kept the methadone system intact and did nothing to alter the drug laws that mandated inner-city heroin users to prison, but it did create a new treatment track for those who had the resources to take advantage of it. To give additional assurance to the DEA that buprenorphine wouldn't spill over to illicit markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, SAMHSA, developed an 8-hour certification course that was required for doctors to prescribe buprenorphine, the first and only prescription drug in the US to come with such a requirement. It's a major barrier to buprenorphine for low-income people, as public clinics generally don't provide incentives or time for their physicians to get certified, while prescribers in the private sector, at least in New York City, can charge fees of up to $1,000 for an initial half-hour induction visit. And then the last technology of whiteness, which is media and marketing. OxyContin's legendary commercial success hinged on its designation as quote-unquote minimally addictive. Purdue used this designation to open an opioid market that had previously been restricted to post-surgical pain, cancer pain, very severe forms of pain. And they were able to expand to a much larger market that included things like lower back pain, moderate lower back pain. They hired a cadre of almost 700 drug representatives who canvassed a call list of 100,000 physicians, and Purdue targeted generalists in suburban and rural areas, predominantly white areas that did not trigger the DEA surveillance, which generally focused on inner cities. Purdue's strategy was successful. It led to a 10-fold increase in prescription opioids nationally, and in the disproportionate uptake of OxyContin by prescribers in white suburban and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. Okay, so to explain this next slide, in my newspaper content analysis, I found that in contrast to articles about the criminality of Black and Latino drug users, suburbanites addicted to OxyContin are portrayed sympathetically in the media as victims of overprescription or as people struggling with real or existential pain. ironically, Purdue's technological response to the first wave of white prescription opioid overdose deaths, their tamper-resistant formulations of oxycodone, combined with the new prescription drug monitoring programs, led many of these legal OxyContin users to look for heroin when pills became hard to get. And one consequence of this has been a whitening of the media coverage of heroin users who have long been portrayed as black or brown. So this is a school teacher in South Carolina, and this is a college athlete, I believe in Phoenix. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet. Manufacturer-sponsored web-based public service announcements featured white professionals and business owners on Suboxone maintenance. And here is an image from the web page sponsored by the manufacturer. Again, I invite you to look at the racial coding. This same website features a link to a Suboxone prescriber locator service created by the Federal Substance Abuse and Mental Health Services Administration. Browsers enter their zip code and they get a list of Suboxone prescribers, most of them in private practice. These strategies created an exclusive yet lucrative segment of the market for Suboxone, making it a blockbuster drug. By 2012, almost $2 billion annually in US sales, second only to OxyContin, which had over $3 billion annually in sales. So it could be otherwise. In France, where buprenorphine was adopted in a universal healthcare system, in a society with a robust social safety net, for generalist physician treatment of opiate dependence in 1996, it was billed not as a stigma-reducing agent for a middle-class market, but rather a public health intervention for overdose deaths and HIV transmission prevention among low-income, largely immigrant heroin injectors. And as a result, buprenorphine was widely adopted among primary care doctors in France in poor communities, and the opioid overdose rate in France dropped 80% in the first 7 years after buprenorphine's approval. Contrast this with the US, where our overdose rates have quadrupled in the first 10 years after buprenorphine's approval. So based on my field work, I suggest that the public health potential of buprenorphine is limited by our racially segregated and market-driven healthcare system, which often leaves both white and non-white patients without the continuity of care that they need for long-term buprenorphine maintenance. And I hope we can discuss at the end of the panel the multiple ways that racialized pharmaceutical capital and disparate law enforcement and treatment systems can be countered with racial justice initiatives and holistic social technologies of recovery from addiction that are currently left out of the pharmaceutical-centered magic bullet thinking of our national strategy. Thank you.
Thank you, Helena. That was amazing, as always. So I entitled my talk, Addressing Stigma and Structures, Our Response to the Opioid Crisis Can Worsen or Improve Addiction Medicine. I'm going to talk about two different type care settings, and all my research is done in the Bay Area, so I'm going to get a little local. And a lot of what I'm going to say is going to resonate with what Helena mentioned, and some of it will perhaps be a little different. But I'm going to talk about a 4-year ethnographic study that I did with women with ongoing opioid use during pregnancy, so talk about obstetrics and neonatology, and then talk about 2 ethnographic studies that I have currently ongoing that look at opioid prescribing in primary care safety net settings for patients with chronic non-cancer pain. And what I really want to talk about is what I feel like is a care crisis in addiction medicine in relation to stigma and structural violence. So the opioid crisis, as Helena mentioned, in some sense, it presents both an opportunity and a challenge because of its unprecedented morbidity and mortality. I think it's waking people up, as it should, as the bodies amass, which unfortunately is how we decide to respond in public health and in care often in the United States to large social problems. And it also addresses the really unique role that physicians and prescribers have had in the opioid crisis, which I'm going to talk about later. And what I really want us to think about today through my research and findings is the relationship between risk and safety, or risk and benefit calculus that comes into play with opioid-related care, and think a bit about what are the sources of risk, where do we identify those and understand them, and what or whose safety concerns are being foregrounded when we think about care. So my work is deeply informed by not only these particular studies that I'm going to speak about, but really 20 plus years of engagement with people who use drugs in the San Francisco Bay Area in a multiple roles, including as a health researcher at UCSF since 1995, but also as a co-founding member and site coordinator of the first women-only needle exchange program, an outreach worker in the Women's Community Clinic for 4 years, and an ongoing volunteer for harm reduction programs that serve women who use drugs. So the first group of study that I want to talk about in relationship to obstetrics and gynecology is a book that I wrote called Addicted, Pregnant, Poor, where I followed 19 women with 23 pregnancies who lived in the daily rent hotels in the Mission District in San Francisco. And as a medical anthropologist, what I like to do, or what we do in our methods when we're doing participant observation, when we're doing interviews or clinic observations, is we attend to personal behavior, drug use, say, mental health and care experiences, but it's in relationship to social relationships, to access to basic needs, education, family, and work, and also in relationship to social policies, institution, modes of governance, and rights. And so one of the sort of larger political contexts that I'm going to speak to that also dovetails on some of what Helena shared is the crack baby epidemic. In terms of framing stigma, I want to say a couple of things about this. People are probably familiar with this research and the ways in which what I want to point out here is that medicine drove the crack baby myth. It was doctors and clinicians who were publishing in their research that was really scientifically unsound in medical journals that circulated it. The media elevated it and codified it, and the social context of racism toward women of color who were receiving welfare entitlements at the time drove social policies that criminalized poverty in the name of the protection of fetus, infants, and children. Now, this research has largely been debunked. The poor science has been revealed. There's been no or very little discussion of reparations or rectification of the families that were torn apart and the multiple generations of children that were washed away in the wave of the crack baby epidemic. But we do know that in sort of the new sciences of addicted pregnancy, that poverty and violence and a variety of social and structural issues that I'm going to talk about in a minute are as predictive, if not more predictive, of poor pregnancy and health outcomes. But we see this coming up again, and that's in part why I mention it. So in Trump's state of emergency speech, he identified precious babies who are exposed to opioids and other drugs in the womb as they endure nausea, pain, anxiety, sleeplessness, just the same as adults undergoing detox, really undergirding this notion of the toxic womb and extending the crack baby epidemic and thinking around prenatal substance use exposure into the opioid epidemic. And what does that do? That creates a mediated image that really upholds and again codifies this sense of women who have ongoing drug use during pregnancy as contributing to the degeneration of the American family and a problem in and of themselves. Now, the women that I worked with in the Mission District had a lot of structural vulnerability that they were dealing with, and I want to just name some of the factors quickly. One was housing insecurity, so they were living in daily rent hotels, such as this one. Trying to manage pregnancy, becoming pregnant, trying to manage pregnancy, raising children, and returning to the hotels in these kind of settings, in built environments that were steeped in poverty and violence and exploitation. They were also steeped in debt because of the affordable housing crisis that we have in San Francisco. There isn't an easy solution, easy housing solution for women who have ongoing drug use during pregnancy. Domestic violence shelters, if they're experiencing violence, are abstinence only. There's a lot of issues that I'm going to talk about, or we can talk about as a group with that. In addition, there's massive criminalization of poor women, and women who use drugs are a specific target of those criminalization and policing policies, which kept women hidden and inside. Inadequate nutrition. Despite ads, this is an ad from my field work, and above it is the window of a daily rent hotel that says everything comes with nutritional information except her, trying to promote food security and nutrition for women who are pregnant. These are the rules in the daily rent hotel, which, as you can see, no cooking in the room. So there's a real structurally produced food insecurity in the setting that I worked. The last sort of aspect of structural vulnerability that I want to speak to is trauma and the experience of homelessness and housing instability reactivating symptoms of PTSD, anxiety, and depression, which we know are associated with drug use. So let's say women enter care. Most of the women that I worked with avoided prenatal care because they were worried about being criminalized, being caught into a system, and losing their children. And indeed, this is maybe a bit hard to see, but the women in red, there's 3, are the women who maintain custody of their children after pregnancy. So their fears were borne out in the sense of being able that sort of maintaining family together was not a possibility for them. So when we talk about risk and safety, what I'm trying to suggest is that we know from the research, from decades of research, that a safer pregnancy, for women who have ongoing opioid use, can include reducing opioid use behaviors or getting on medically assisted treatment. We have really good clinical protocols for that, but it also includes housing stability, food security, income, and trauma-informed care. Risk, however, is largely fetus-focused. So we don't tend to think, when we think about pregnant women with opioid use, we don't think about a whole woman. We don't think about a woman who had a life and perhaps a drug dependency that she was struggling with and needed help with prior to getting pregnant. We also don't warn women or talk to women about discrimination and adjudication that might occur for them when they enter healthcare, which is incredibly acute for poor women and women of color. This is rarely discussed as a risk when we think about opioid-related care. Safety from criminalization for substance use and substance use disorders are rarely foregrounded in clinical care. Pain management during delivery and postpartum is considered often too risky for women who have opioid dependency. Best practices for medical assisted treatment and for neonatal abstinence syndrome, which again, are well researched and well documented and not refuted by major medical organizations. There's a lot of agreement. There's not a lot of disagreement about how to work with a woman medically who has opioid use during pregnancy. However, the toxic womb as a stigmatizing framework means that those healthcare mandates can be ignored and in favor of criminalization. So women are at risk for not having their reproductive health needs met because of drug use stigma. So how do we dismantle the toxic womb? First, I think we need to start by recognizing that racism is the etiology and a driver for the toxic womb. It has that history in the crack baby epidemic, and as we can see with some of Helena's talk, it's a perpetuator, and so that needs to be discussed. We need to talk about inaccurate science and the language that it reproduces or produces in the media. Promote evidence-based clinical and social interventions. We have those, and don't start and stop with pregnancy. In terms of structural interventions that can help for women, we need to think about criminal justice reform, anti-racist health policies. I mentioned this earlier, harm reduction housing for women who become pregnant while using drugs, pre and postpartum and family centered. There really isn't a housing solution that's straightforward. We need to think about that as a policy issue. We also need to consider why evidence-based clinical care isn't being used when we know so much about MAT, neonatal abstinence syndrome, rooming in. We need to address this in medical education. And so this has been a big part of my work in the past 3 years since the book came out, is to really try and bring a structural competency framework to medical education and really think about addiction medicine as a site of need for medical students, whether you go into that for specialty or not. And then we need to address the gaps in knowledge between child protective services, the clinical realm, and the treatment realm, because they're not having conversations that are particularly productive for women who have drug use during pregnancy, whether in the prenatal stage or particularly postpartum. So how are neonatologists and OBs being in the same conversation, have the same understanding about what actually is best practice? There's huge gaps there. Those are some structural suggestions. I'm going to move on quickly and talk about my work with chronic non-cancer pain and substance-using patients in primary care safety net. And you'll see a lot of resonancies, actually, between this work, or at least I hope you will. So I have one study I completed. It was a NIDA-funded study, and one study is ongoing, looking at pain management, and the second study is looking at the consequences of reductions in opioid prescribing. They share pretty similar methods. We recruit patients who are in primary care safety net, who have a chronic non-cancer pain diagnosis and a history of substance use. We recruit their clinicians, and then we interview them, and then we visit with them in clinical encounters. So we actually observe the clinical encounters. And then we go with the patients into their community, into wherever they're living, and see how they're managing their pain, pain, their opioid dependency if they're dependent, or how they're managing their pain relative to reductions that they might be experiencing. We also interview a whole series of stakeholders for this study. So that includes DEA agents, people who've begun overdose prevention programs with naloxone distribution, health policymakers, people who do advocacy around insurance paying at that level to try and get at some of those structural issues that I'm going to name. We've published a bunch of papers from this study, and if you're interested, I'm happy to send you those. I'm going to focus just quickly on some of the results. So first, here's a similarity with primary care in terms of opioid prescribing, is that medicine and industry both have a role, particularly in the perpetuation of the uncritical perpetuation of flawed science and research in opioid prescribing. So it was sort of a perfect storm, and Helena mentioned a little bit of this around the uptake of early research that argued and was actually really taken out of context and sort of taken up in a similar way that the crack baby research was really taken up and misinterpreted in a larger public and clinical space around whether or not opioids produced dependence or addiction in patients when they were treated for chronic pain. At the same time, there was a big concern about undertreatment of pain. And so the pain as the fifth vital sign movement was really trying to be patient-centered and responsive. And then we see the role of Purdue and pharmaceuticalization and the push there, which we've already talked about. So let's talk about stigma. In our research, the main drivers of stigma are sort of along three dimensions. One is that chronic non-cancer pain patients in primary care who feel like they've been iatrogenically addicted, they're in their terms, or they've been addicted as a result of overprescribing, really want to distance themselves from an addict label, or even from an opioid use disorder label. And why is that? Because that's a terrible label. That's a highly stigmatized, that's probably one of the most stigmatized sort of social roles that you can occupy in any healthcare. I would argue that people with substance use disorders are one of the only holdout categories that can be treated absolutely miserably without regard for dignity or human rights in healthcare settings with very little, Helena's shaking her head, with very little backlash or adjudication. And that's a huge problem in addiction medicine. Secondly, experiences of racialized care disparities. So one of the solutions to the opioid overprescribing epidemic in primary care is to do universal precautions. And part of universal precautions is doing UTOX testing with patients, but it's also doing informed consent through controlled substance use agreements, like the one that you see here, or they're sometimes called pain agreements, where you sit down and the clinician and the patient discuss the risks of opioids so that they understand and what's going to happen if people misuse their opioids, if they don't use them as correct, that kind of a thing. Among our African American patients in our study, in the first study that we did, universal precautions were not perceived as universal at all. They were perceived as targeted and anti-Black. So it was very clear to those patients, based on their experience of a racialized healthcare system, a racist healthcare system, as Helena mentioned, that they were being targeted, accused of being addicts, and having their pain mismanaged as a result of their race. So we need to be aware as we sort of put these technologies in place that this is how they're being uptake because of the context. So structural factors. So in addition to stigma, the structural factors that are weighing in on primary care physicians who are trying to do management of opioids in what they feel like is a safer way are these law and order drug policy climate in the media, so the prosecution of drug dealers for opioid overdoses. So there's several federal initiatives that are along these lines. The California Medical Board has recently implemented the Death Certificate Project, where they're sending letters to providers about their prescribing behavior, and that's created a tremendous climate of fear. There's an opioid surveillance means increased visits, which is an increased healthcare burden in terms of costs, and also an increased burden for patients because they have to show up at these safety net clinics more frequently. And we know that economic insecurity increases depression and exacerbates anxiety, which worsens pain. If you're sleeping outside and you're housing insecure, your chronic non-cancer pain is going to get worse. We have several patients whose chronic non-cancer pain etiology comes from police and community violence. So gunshot wounds or multiple experiences of police brutality have produced the chronic pain that they're then managing later. And we have changes in an opioid drug supply right now. The fentanyl-associated overdose mortality in San Francisco was 3 times higher in September than it was the month previous. So fentanyl is here, and we need to think structurally when patients are being tapered whether or not they're entering into a community drug supply that's become increasingly dangerous. So in terms of, I'm almost done. In terms of risk and safety, patients may have a shared understanding of the medical legal risks associated with opioids, but clinicians are concerned about patient overdose, community harm in their own licenses, and patients are concerned about addiction, undertreatment of pain, and discrimination. So let's see. Criminal justice responses that are concerned about diversion and community harm alone are probably going to perpetuate fear. And patients experiencing rapid taper are entering into a drug market that's quite dangerous. So lastly, I just want to say that in terms of opportunity, we have evidence-based standards. Again, there's a lot of really good research and support for medically assisted treatment and neonatal abstinence syndrome treatment. The challenge is we know a lot about clinically appropriate care, but students are often not taught it, and health professionals often don't practice it. So I want to say that the opioid crisis is unprecedented, but it's not new. And I think we heard that from Helena's talk as well. I want to argue it's unprecedented because it's not new, because we haven't been dealing with structural vulnerability and stigma that is producing an opioid crisis, that addiction medicine, unless it shifts its focus to think more about where risk is coming from and whose safety has been considered, it won't be the opioid crisis, but it'll be the methamphetamine crisis. It'll be something else. And so that's my call to addiction medicine. Thank you.
Thank you, Dr. Helena Hansen and Dr. Kelly Knight. I'd like to invite the 3 panelists to come up here now, and they each have a major 10 minutes to respond. I mean, obviously, you're seeing everybody has a lot of expertise on this topic and could talk longer, but we do want to open it up to everybody else.
All right, great. Hi, everyone, and just phenomenal talk. Both of you were so brilliant and really thought-provoking here. And thank you so much, Dr. Kaufman and Dr. Lucy, for inviting me to be on the panel. So I'm coming in from this, or looking at this, with a few different perspectives, and I do think this is an opportunity for us to think about how we can move forward. So how I'm looking at it is from the perspective of a public psychiatrist, so I'm somebody who works in the public sector. I'm also a scientist. I'm a health equity advocate, and I'm also an administrator. So I'd like to use data to fix this, to try to move things forward for this population in an equitable, for our population in an equitable way. And so I think I was trying to sift through some of the noise and think about what are some of the 2 main questions I have. One is who should we be targeting? You know, we talked about how the media and the public has kind of drawn us to start thinking about this as a white kind of problem. As we know, that's inaccurate, and addiction is much more beyond that. But a quote actually that I found very interesting that happened this week. Had anybody seen something on social media about a young woman in Vermont who died? So raise your hands. And did you guys see this, also the response by the police chief in Vermont? So he had a really interesting response. So she was a young mother, you know, very typical of what Dr. Hansen had shown in the pictures, beautiful young woman. And he said, well, did readers think this was the first time that a beautiful young mother got addicted to Oxy and died from it? And what about the rest who weren't as beautiful and lived in downtrodden cities or the Rust Belt? They too had mothers who cried and blamed themselves, right? And so it was, and he goes on to actually think about different structural ways to address addiction. It's worth the read by this Chief Brandon Del Pozo. So we recognize that it's different populations, but I think something that we do in medicine and in healthcare is often say, well, it's the other, right? We don't look at some of the problems that we have ourselves, some of the problems that people around the room might have with addiction, problems that our family members do, our friends, our colleagues. 20% of physicians have substance use disorders. So I think that it would be unlikely for many people in the room to say that they don't know somebody they love or a colleague that has an addiction problem. So it's all of us. It's not just these other patients that have these problems. It's our issues as well. So I just need to kind of say that. And my wish really for where we can move forward is that we start doing more universal screening so that we can reduce some of this inequities in identifying care and really trying to deliver the care that the different populations need. And that brings me to the where. Right, and so I think Kelly was talking about this as well as about stigma, right? So I'm a psychiatrist. I know lots about stigma because it also affects most patients with mental illness and these substance use issues. How our system is structured is typically that things are siloed care, right? And so you go and you were supposed to go to this substance use treatment facility where nobody wants to go there to receive care, right? And I do think that we should start thinking about how we set up our system so that whatever door these patients come in and touch, whether they are coming into primary care or specialty mental health or OB or other clinics, that they get screened and referred and ideally treated there if possible. This is in the future to make that kind of universal, but that's really where we need to be. And that's starting to happen in some places, but it's not happening everywhere. And we need to start, I believe, approaching it in that way. I think also, Dr. Knight was talking a lot about these pregnant mothers and these, and that's an opportunity I think we have. So one is so my first point had been around like looking at all the places that we touch, that patients touch. But then mothers actually come in and fathers, right? And they bring their kids in and they bring them into pediatric care. I actually think we have an opportunity there to reach some families and do more enhanced screening for both mental health issues and also substance use issues and really make a difference in these people's lives. I know they're starting to do some of this work in other settings, but that's a real opportunity. And I think of it because I can remember so clearly, a decade and a half ago being a medical student here and treating and having there be a baby that was just born in the NICU. And it was born to a mom who had been abusing heroin, and the baby was just screaming and wailing, and it was the most disturbing thing I had heard. And it was withdrawing from the child was withdrawing from heroin, and I remember feeling so angry. I was so angry at this mother, and it was a misplaced anger. Right? I didn't know then what this was. As a psychiatrist, I do. Instead of thinking, what had this woman been through? What happened to her? Why did this happen? And so it was an opportunity that we have when we're in these different settings, seeing the baby that draws everybody to try to help, and to step back and go, hey, what about this family? So stepping beyond kind of our traditional, stepping beyond the patient that's there. And then I think the final kind of where I think is we need to step outside of the walls of the hospital. And go out into the community. I think there's opportunities for us to deliver care in jails, in jail settings, in correctional facilities. They're doing some of this work here in San Francisco, as well as some other settings. That's an opportunity. That's where people are. Thinking about pairing with faith-based partnerships, and actually reducing some of the stigma and delivering care there, going to family justice centers. In New York, they're delivering care in family justice centers where people are going in because of domestic violence, and they're delivering some mental health treatment, but expanding it to more to substance use. And then on the street. So something that I feel very proud about is some of my fellows now are going and doing what's called street psychiatry, which is also happening here in San Francisco. But in Oakland, they're going out to encampments, homeless encampments, where there have been large rates of opiate overdoses, and actually delivering buprenorphine out in those settings, not in our traditional hospital setting. So I think we need to. I'm really looking forward to having more of a discussion about it, but I think where I'd love to see our university move and our health system move is think about kind of more universal screening and not and meeting patients where they are and where they're already going. Thank you.
Is somebody going to keep time for me? Oh, Thank you. Who's in the room? Who are learners, students, faculty, community members, public health folks? San Francisco General? I maintain clinical practice there too. I could say a million things, so I'm going to try and keep to my time. First of all, thank you all for having me. I'm going to take this to a 30,000-foot view, both including nursing and public health and reproductive justice and a whole variety of other things. OBGYN Grand Rounds this morning, Dr. Kamara Jones was here with us, and for those of you who know public health, she's the former president of APHA, and she was just incredibly eloquent in talking through racism in healthcare. And so I'm coming off of that, and it was our first Grand Rounds. But I want to draw your attention to our last Grand Round speaker in OBGYN this year, in June 4th of 2019. It'll be Dorothy Roberts. And Dorothy Roberts' work has sort of been infused through a lot of our different slides, a lot of our different imagery, but I feel like it's important to bring her into this room and to bring her into this conversation. She's a distinguished professor at Penn in the School of Law. One of the most interesting things about her is she wrote a book called Killing the Black Body, Race, Reproduction, and the Meaning of Liberty, and that book came out in 1997. And she was one of the first people to really critique the, falsity of the crack baby and really got into gendered racism and really talked a lot about how we surveil pregnant people, about whiteness, about the problem of the default human, and particularly the default human in the context of health services provision, where our data and clinical services are all built around a fictitious person, and that fictitious person generally is a white male. And so, Helena, I thank you for putting your work in the context of whiteness. I also think that in talking about stigma, when we want to think about that, I just got back from the North American Forum on Family Planning. It's a joint medicine program between Planned Parenthood, the Society of Family Planning, and the Association of Reproductive Health Professionals. And there were 4 panels on opioid use and working with individuals, whether they're seeking contraception, family planning, abortion, or continuing pregnancies. Because one of the real issues is that there's a real gap in the clinical care providers in obstetrics and gynecology around how to really be able to manage these different conditions and addiction, and at the same time not add to further stigmatization or criminalization of pregnant people. And so I want us to sort of be thinking through sort of what would a justice approach really look like if we were really going to actually manage addiction and pregnancy. And I think, some of the comments that you made are really, really spot on. And I just want to tell you about 2 things that I would love to put sort of on your radar to think about. I do a lot of workforce work and I do a lot of community engaged work because I believe in the capacity of humans, irrespective of whether they use substances or not. So one of the reasons everybody thought I was crazy when I said, we're going to develop a doula training at Santa Rita Jail and in San Francisco Jail. And they were like, why are you going to develop a doula training at the jail? And I said, well, because the life-changing programs or the reentry programs for incarcerated individuals were, computer technician, electrical engineer, jobs that are really geared towards, men and skills and not service economy and people where 88% of them are already parents. And so many of the women that we knew that were in Santa Rita Jail and the San Francisco Jail were driving for Lyft and Uber, or they were working at Target, or they were doing other types of shift work, right, in the service industry. And so the idea that you could make a living wage or that you could even actually support yourself and feed your family and pay rent in San Francisco or Oakland, which is where I live, on a salary in the service or the gig economy when you're not actually like a tech person is really problematic. And so we wanted to be able to afford them not only some life skills, but also the capacity to be able to generate income. And we would get the twofer, right? Because most of the women who were in jail were women of color. And so we were like, we could get women of color taking care of women of color, and then we could deal with the structural fix of why we have so many women dying during pregnancy, that we could actually have culturally appropriate, culturally relevant doulas to be able to do that work and to support those individuals. So I think we need to change our thoughts about how we conceptualize people who use substances. I always think about them as our future workforce. And I think we need to start thinking about that. They are some of our greatest teachers, not only in clinical work, but in life, and how to manage systems. They are some of the most resilient and some of the most creative people on the planet. And I say that in the context of avoiding criminalization really being able to do the things that you need to do in your life and use substances and still be able to like show up for things, that requires a skill set that I think is like expert level. And I think we need to start talking about it in that way. The second thing I really, really sort of want to put into the room and sort of think about is, you know, I think that in my experience, in my research, I mean, so let me bring it back to the preterm birth initiative. So, you know, we've been doing work in Fresno, in Oakland, and in San Francisco, and one of the most interesting things about listening to people who have public insurance, listening to people of color who either live in public housing or, you know, park on couches in public housing, and people who are trying to experience and navigate both pregnancy and raising their existing children. They have so many things to teach us about performative expected behaviors and sort of how to really, really be able to perform in a way so that they can avoid many stigmatizing behaviors, or to perform in a way to be able to get the things that they need. And so there's a real hiding of one's authenticity. And I think, you know, this gets to some of the dual consciousness that I think Black people are really expert at. And so I think we really sort of need to start to unpack how we're thinking about our interventions. I actually was smiling when you were talking about universal screening, because I can tell you in pregnancy, there are many unintended consequences to universal screening. And so I would challenge us to say, what are we screening for and why do we want to screen? Because is it really about, you know, surveillance during pregnancy? Is it about, you know, our uncomfortable relationship that we have with criminal justice? Is it documentation to avoid lawsuit? Like, what is that? Why do we need to know that people actually use substances during pregnancy? And we think it's because there is something that we're going to be able to do, whether it's connect them to services or to be able to make sure that they can have the healthiest outcomes possible, right? But I also think there's an unintended consequence to that, which is, you know, we are lucky enough to know when people actually admit that they're using substances, or when we believe them, or we will biologically test them, right? But that's not true for everybody. So this whole idea that we actually think that we're getting at, you know, the individuals who actually are using substances with universal screening, I think is actually a really problematic one. And if there's any obstetrician or reproductive health folks who are in the room, I would love for people to opine about this. I've talked with the midwives at ZSFG about this quite a bit because they have not taken to universal screening. And I mean screening in verbal, not in urine or blood testing. I actually think we need to really unpack why are we doing that and to what end? And then how does that change the clinical trajectory that we are working with individuals to meet them where they're at. So those are sort of my comments, and I would love to hear some questions about anything and everything that I've said. And again, thank you for having me.
Thanks for having me. I am a little bit intimidated to be the white guy ending up the talking here. I gotta acknowledge that up front. Also gotta say, as the drug treatment representative / primary care doctor, I'm a little bit intimidated, but I guess I'm gonna try to give a couple hopeful comments. Number one, especially for the people who are medical students in the room, who will be clinicians in the future, and tell you a couple patient stories. Okay, so the first one I wanted to tell is important because I used to practice in the one part of New York where you saw lots of methadone and lots of buprenorphine. You probably didn't see it because she was only given a short amount of time to show her slides, but in the South Bronx, where I used to work, there's a lot of methadone maintenance treatment programs, and in fact, working out of those treatment programs and in the primary care clinics, there's a lot of buprenorphine that's provided in primary care offices as well. So I used to work there, and when I was there, I had a patient who injected cocaine. She didn't have any more veins, okay? So she injected cocaine into an ulcer that went down to her bones in her forearm, and it took up her whole forearm. So in order to inject the cocaine, in order to get it into her bloodstream, that's where she went, okay? So I didn't know what to do for her because she did a good job of taking care of the wound, and we kept from getting sick. And so we talked about that. We talked about some other sort of harm reduction measures that she could do. But I didn't know what to do with her. And so I presented the case as part of a lecture that I was giving to the residents on cocaine, about physiology and treatment, all that stuff. And they came up, I mean, they were amazing. They're social medicine residents. They came up with this idea, why don't you ask her about smoking crack instead? And I said, I hadn't thought about that. I honestly hadn't talked about that. So I'm all fired up. And I go in to see her, or she comes in to see me, rather. And we had a fraught relationship, I have to say. But at this point, it was good. And I said, ma'am, have you ever thought about letting this thing heal up by just smoking cocaine every day instead of injecting it? And she looked at me like I had just belched in her face. And she said, I'm not a crackhead. And I tell this story because all of the stuff that we've heard, right, is about stigma. And it's, in some cases, it's about whatever the opposite of stigma is with regards to buprenorphine as opposed to methadone. So I tell this story to point out that the association of a drug, a chemical, right, with badness or goodness is utterly crazy. Like, that doesn't make any intellectual sense to me, right? Is it the chemical or the way that the chemical is prepared that really matters, right? Or is it the way that you use it that really matters? I don't, to me, I've gotten past that point most of the way, I think, most of the way. But I would ask people when they are thinking about drugs or people who use drugs, what do they picture, right? And if it's not you, right? If it's not you looking in the mirror, then maybe it's time to do a little more digging, a little more work. Because it isn't the drug that's good. It isn't the drug that's bad. And we need to come up with a way to figure out how to just eliminate that value association or value judgment from our thinking. Because that enables the racialization and the stigmatization of both the drug use and the treatment. Now, I need to react a little bit to some of the stuff that came up earlier, because that was my task that they asked me to do. So one thing that I just want to point out for everybody is that buprenorphine and methadone save lives. Okay? Both of these drugs have been demonstrated as a mortality benefit. So does that make them good? Does that make them bad? No. It just makes them a treatment that we can employ to help people who have an opioid use disorder. The other thing to note is that heroin, diacetylmorphine, assisted treatment, also has been demonstrated to help people with opioid use disorder. Okay? Injectable hydromorphone, commonly known as the trade name Dilaudid, is also been demonstrated to help people with opioid use disorder decrease and eliminate their use of street opioids. Okay? So just because it's not legal in this country doesn't mean that it's not been used by other societies, right? The other thing to think about there is like, well, what does it mean that we have somebody with an opioid use disorder and we give them their drug? Like, isn't that distasteful? In fact, if you are interested, it depends on what you're interested in doing, right? If you're interested in helping somebody no longer engage in the behaviors that hurt themselves, that hurt their families, that hurt the communities that they're in, you definitely want to give them treatment, right? And so it's incumbent upon us to figure out ways to make that a possibility, right, as clinicians. And the folks who are interested in policy and are able to affect those kinds of changes need to help us out on that front as well. Because otherwise, if you have a situation where the only way, for example, to have a safer injection facility is if it's underground, in order to avoid prosecution, you're going to end up with the same, and it's a resource-limited sort of situation, you're going to end up with the same racialized practices that take place in the above-ground situation, right? It's going to be worse if you have limited access. So much like the buprenorphine success story in France, everything needs to be a little bit more widely available. We need to have more treatments available. The last thing that I'll say, because I'd like to, oh, I'm almost out of time anyway. Okay. I would really ask for people to consider, regardless of what you're going into, and I'm going to speak to the students real quick, regardless of what you're going into for your career, please do consider getting training to be able to treat opioid use disorder, to treat other substance use disorders. It's going to be offered at least as an elective starting next spring for people to get the buprenorphine waiver course. We're going to try to make it a requirement if we can get some help. But the idea that it's not your job, right? Like that it's only my job to drain the abscess, it's only my job to treat the infection, it's only my job to replace the heart valve. That's just bullshit, okay? We treat people, not diseases. So that's the last thing that I'll say, and open it up for questions.
Thank you so much to all three panelists. Now I want to invite Helen and Kelly to come join the panel, to sit up here, and we'll open it up to your questions. We only have one movable mic, which I want to keep here for them. So when I raise hands, when I call on you, I'll try and really move around the room. Speak loudly. And you can address, of course, the whole group, or one person, or various people can respond to whatever you want to talk about. And please say your name and your placement here, like faculty, student, what school, what class, like that. So we'll just open it up and be interested in your comments. This was a lot of material.
Hi, I'm Brad Shapiro. I'm always a learner, but I'm faculty as well. And I was wondering if you guys could comment a little bit on the racialization in the 12-step and abstinence-based world, what you can say about that.
So that's a complicated field. And actually, my book is about a very different approach to addiction that's still quite widespread. I'd say in Black and Latino inner cities in the U.S. as well as on the island of Puerto Rico, totally abstinence-based and Pentecostal Christian approach. 12-step also a Christian-based. I mean, it came out of an evangelist movement in the 30s, of course, and it very strategically got rid of much of its explicitly Christian trappings and also adopted a language of disease that's very complicated. One thing I can say about 12-step right now is the active debates around whether people on maintenance treatment should be admitted to 12-step groups. And then there's some groups that are actually methadone anonymous and buprenorphine anonymous that are a reaction to any resistance to that. The question being whether you're abstinent if you're on maintenance medications. So it's a really complicated and evolving field. You asked about race. One thing as an anthropologist that I'm always tracking is the organic nature of these movements, and they look very differently depending on where you are and their history to each of these movements. So the Pentecostal ministry movement, rooted in a moment in history in the turn of the 20th century that was actually an explicitly originally multiracial movement and quite attractive to African American and Latino practitioners. And so much of the discourse in the ministries that I write about is actually about toxic environments. So you would think that a moral, spiritual approach to addiction would be very much blaming the faulty and weak individual, when actually much of what they're talking about is toxic environments, the fact that they spiritually are resisting the environment that they're living in and trying to build a Christian community explicitly against that. So I think it gets complicated, but that's where the anthropologist in me is advocating for a much more nuanced approach, much more nuanced understanding of where people are coming from. I really appreciate the comments that Monica McLemore, I hope I'm pronouncing your name correctly, made about the agency of people who use drugs, because that's something that's very rarely talked about, especially in clinical circles. We make this automatic assumption that if you're addicted, you lack any agency, and that's rooted in a biomedical concept of addiction as something that means you have total lack of control of yourself. When if you've spent any time with people who use drugs, you realize it takes incredible ingenuity and skill to get through just a day. And some of our best partners in this current overdose crisis, are people who use drugs. And we have to embrace that. And one thing I like to now remind audiences is that, I work in a city with a union of active drug users. In Vancouver, I'm learning more and more about the history of their incredible harm reduction movement there, which came out of the blood, sweat, and tears of people who use drugs. They were activists. They stood up against police. I did not understand, because Canadians are stereotypically so gentle, right? Like, in this country, we think Canadians are so benign, when actually there was a lot of police repression in Vancouver. And who was it who stood up against them? It was people who use drugs, who were defending their own interests in partnership with some really brave clinical practitioners. So I thank you for raising that. I think we have to think much more carefully and in a much more nuanced way about how movements start organically, how they can be our collaborators and our partners in trying to address this problem. Often they have a much better understanding of what's going on the ground and what they need than we do as clinicians.
I want to put two things on your radar in terms of not only substance use and 12-step programs or abstinence or the abstinent requirements. There was a sort of very scary trend that's going on around Title V and Title X. So Title X is the family planning programs that we have in Title V, covers births in the United States. I mean, right, half the births in the United States are covered by Medicaid or public insurance. And so with the recent changes at DHHS, we've seen a lot of crisis pregnancy centers and a lot of fake clinics or other types of institutions that actually don't have clinical expertise and do not base their services and practices on biomedical science or actual evidence. And so one of the things that we're very much concerned about, at least in the Title V and the Title X world, is where we have federally qualified health centers and other type of publicly funded health services for low-income individuals, that we're seeing a lot of need and pushing of abstinence and the refusal of providing people with FDA-approved contraception, as well as fact-based information about parenting, adoption, or abortion. And so it's really, really becoming an issue in terms of also having those institutions now applying for opioid funding through the CDC and other opportunities that have come forward. And really, I think it's just a recipe for disaster. And so there's public comments that have been going down. There's a whole strategic plan through NICHD, the National Institutes for Child Health Development, or the Unischreiber Institute. But if you can make some comments known, and please understand the intersection of understanding, addiction medicine, opioid use, and pregnancy, and particularly public health interventions is really an important place that we need these voices to really, really be able to talk about why, abstinence across the board, using that as a justification for removal of all other programs. We need voices from all different types of individuals, and this is one intersection where I actually really think it can matter.
Thank you. Any other? Yes, sir.
Hi, my name is Alex. I'm a student in the School of Medicine, so I guess I'll be taking your elective coming up. I was wondering, so there was some comment made about prescription monitoring programs, and I wonder if maybe you can give personal experience with it. There's been some controversial data on whether or not it's actually effective.
You want to repeat the question?
Sure. Yeah, it's about prescription drug monitoring programs or statewide programs where physicians can look up, it's called Cures in California, and so you can look up and see if people are getting prescriptions for medications and where they're getting. So for example, if you have a patient in primary care who you're maintaining on opioids, and you can look up the Cures and find out if they're being co-prescribed benzodiazepines in psychiatry, for example, or they're receiving opioids elsewhere, or they're on methadone in a way that, so they were introduced. Helena can probably speak to the history a little bit more about how they were introduced on a national level, but they were introduced as part of the response to increase opioid prescribing surveillance. And so they're one of the things that happen in the universal precautions that I mentioned. Your question was about how the data. Yeah, so the data is not, has not been that they actually help reduce morbidity and mortality, specifically on a nationwide level. That's my understanding. I think different states might have different, and I think, the amount of publication in public health around opioid-associated research is exponential. Every week there are literally 100 new articles with national data. So it's a very emergent field of evidence, I guess I would say. But urine toxicology has also, shown the same. So and then I actually can't speak to the controlled substance use agreements. I don't know national research that's been done on whether or not those decrease morbidity and mortality specifically associated with opioids. But prescribing has gone down. So, and I think that there's a whole host of structural reasons, but fear and surveillance is a piece of that for sure. And part of it is also primary care physicians trying to be more cautious and thoughtful about the risks and benefits of opioid prescribing, which I think is legitimate.
Just want to quickly add to that I did a study, kind of maybe a microcosm of white America and Staten Island, New York City's whitest and most affluent suburb, or borough. I'm sorry, it is a suburban place, but it's a borough. And one thing that we interviewed about was the prescription drug monitoring program. And it turns out that many of the people we talked to who were potential prescribers and providers said that the impact was the legal liability of it discouraged them from dealing with anybody who had any substance issues, and that it discouraged them from providing buprenorphine as well, that they felt it exposed them to risk. So it's yet another instance of very simplified thinking in our policies about drugs, the way they work, and of course the idea that clamping down on prescribing unilaterally was going to solve this problem. We're seeing a raging heroin problem and fentanyl problem now as a result of that very linear, simplistic thinking.
Just one thing, in California, you now have to check a cures report every 4 months if you are prescribing something that gets filled in a pharmacy that's a controlled substance. So if you have persons on chronic pain, every 4 months it has to be checked. And the clever thing about this is in California is that it's run by the Department of Justice. The statute is written in such a way that it says that the prescriber has to log on, and so they can track your login to see if you logged on. You can't just have somebody else run the report for you and say that you reviewed it in the medical record. You have to log on. So providers out there know that, and it has the potential to have a chilling effect on drug treatment because you prescribe buprenorphine, people fill it in the pharmacy. That's the largest source of buprenorphine treatment in this country. But methadone maintenance, of course, is a whole separate system, as was pointed out earlier, and thanks to federal regulations protecting the privacy of individuals who are in substance use treatment, that information does not end up in the cures report, in the prescription drug monitoring program in any state. So it's an interesting, it's cleverly written if you wanted to put the brakes on people treating people with buprenorphine, but it's in addition to treating people with chronic opioids or benzos.
I want to. We have the founder of the Haight-Ashbury Free Clinic here, so give him the floor with the next question.
Go ahead, David.
Thank you. David Smith, founder of Haight-Ashbury Free Clinics, adjunct professor here at UCSF. I'm in recovery myself, and my wife has been in recovery from heroin for 42 years. Thank you. Although it's not the focus of the panel, I believe only Helena accurately described what medication-assisted treatment is. I know that the speakers had a totally different focus, but medication-assisted treatment is the interaction of medication and psychosocial recovery. Since we have students in the audience, if they listen to just a majority of the speakers, they think all treatment was just medication, and you accurately described it. I'm also concerned that it was a misrepresentation of the 12-step process. The 12-step process is step one, you feel you've lost control over the drug, and you don't have to be abstinent, you just have to have the desire. And there is a certain tension between the medication and the psychosocial, but I believe we're overcoming that. I know, Scott, you've been a leader in that here in San Francisco, where the 12-step groups do not ban somebody that's on medication. Dr. Bill Wilson said that it's a medication, don't play doctor. And so I just feel, since students are learning about it, they need to have an accurate representation of what these modalities are. I've treated a large number of pregnant addicts in my life. Their major focus is their child. What they want is the medication helps them get there, but what they want is the psychosocial aspect in dealing with their child. That's the T of MAT. I know that we're working on training addiction nursing. I just left Glide Church, Allie Mayo and myself, and I really agree that the focus on just the white 12-step is a problem. But at Glide Church, they have many different groups. They have Native American, they have African American. I went to one meeting in which their priest was their higher power. So I just, and it might be good, Helena, since I feel you hit upon it the best of the panel, if you could elaborate on that. I'd like for you to elaborate on that.
Thank you for the opportunity to do that, because I think you're right. The way that I brought up 12-step was really cursory and misleading. I think the point I was trying to make is that we as clinical practitioners really have to know the field that we're working with, because 12-step, like so many other movements, is rapidly evolving and also locally very different. So the groups here in San Francisco are actually going to practice differently than groups in other parts of the country that may be not as far along in terms of their understanding of what abstinence is, their understanding of where 12-step can fit into treatment. So I absolutely thank you for bringing up that nuance. And my understanding is that one of the places that has the highest density of 12-step programs right now in the world is actually Iran, for very complicated historical and political reasons. But so this movement that started with a group of evangelists in the Oxford movement is now the major mode of treatment in a Muslim country. And so that just points out how complicated it is, but also how important it is for us as clinical practitioners to understand what is a resource and what's not a resource, and how we can work also with people in communities to move them a little bit further along when they need to be moved along. Because the fact that 12-step groups are evolving and changing in many parts of the country and much more welcoming to people on medically assisted treatment is the result of some interventions, of some people taking 12-step leadership aside and bringing it up in groups. So I just encourage us all to think about ourselves as a part of a dynamic field that will include community engagement, that will include educating ourselves about what's available, what is a potential resource that we can bring along, what is an actual resource, and not to rely on stereotypes either, because thank you, I think I may have reinforced a stereotype about 12-step programs that's actually not accurate in a lot of parts of the country. And in terms of the racialization of 12-step, with the example I gave, I mean, it's quite an adaptable model. And I think it's only one of many examples of psychosocial approaches to addiction that we have to elevate and value and bring much further along. That's my fear about our pharmacological, our pharmaphilic moment. You know, we're in the moment of such heavy pharmaceuticalization. It's really a political economic stance. It's really the power of the industry of pharmaceuticals. The fact that we now are thinking about addiction treatment as simply a drug, a magic pill. And Purdue Pharma, the manufacturer of the OxyContin that led down this road, is now patenting forms of buprenorphine as opioid dependence treatment. So it's full circle. You know, it's a self-contained money-making venture, and I think we have to be very conscious of that too, and ask a lot of questions, such as Kelly raised, about what are the social structural interventions that we need to be advocating for and working towards. We can't drink the Kool-Aid of a magic bullet.
I think, let me open it up to some other, yes, back in the back, your hand went up first, yes. Yes, you. Stand up and speak loudly.
Okay. Hi, my name is India. I'm a medical student, and we spoke a little bit about methadone maintenance programs and how they are super regulated, and you have to go there almost every day. And I know there's
Every day. Christmas, every day.
every day, and I know that's a hassle, and that can also be like this surveillance of people who are using drugs. But there's also opportunity to have like people connected to services and have there's benefits and there's disadvantages. And I'm just wondering, what are your thoughts on decentralizing that process, or maybe making methadone open to primary care offices, private offices, and what that would do or what that wouldn't do?
Yes. But even that cuts both ways, right? Because of exactly what you just said. So at OTOP, where Brad works, he's more than just a learner and is the boss. We really focus on what you're saying, like connecting people to services, but really what connecting people to services often means is connecting the services to them, right? So, you know, a few years ago, the big talk was about patient-centered medical homes and how that was the big deal. Well, our shop is a patient-centered medical home. People come there every day because they have to, because of regulations, and because they're interested in improving their health. Okay? So when they come there and they can get their Hep C treated, they can pick up their antiretrovirals at the window and wash it down with their methadone, right? So that they keep their viral load suppressed. When they can get their psychiatric care there, that's what you want to do, is you want to bring the services to the people where they are. So methadone maintenance offers that opportunity. Now, the flip side is exactly what you point out, is that it's such a hassle that we have to do, it's very hard to keep people in care, and some people don't need that level of care, right? And so one of the ways that it used to have to happen, right, was that you would take people off of this thing that has been working so well for them for years, decades in some cases, and switch them to buprenorphine. So potentially destabilize them in order to move them to a lower level of, quote unquote, lower level of care, where they're just getting a prescription and they go fill it at the pharmacy. You break that connection that they've formed with their counselor over many years. So it has some problems, right? We have this weird, we call it weird, but it's not that weird. It's weird because it's unique, program in San Francisco where folks are able to transition to getting some prescriptions from their primary if they're at three specific clinics within the DPH, and they get a prescription and they go to the two specific pharmacies and get an observed dose by the pharmacist there, and then get a bottle to take home. And so it's part of their primary care visit, right? They also have a counselor at the clinic that they see. So it's a very small model, and it would be great if it could be expanded to places where it's harder to get to a methadone maintenance treatment program, for example, rural areas, because then you would be able to get people options for their treatment, not just methadone, other options. But you hit the nail on the head. it's like that intersection of, for some people, the methadone maintenance treatment program is an amazing, life-saving thing, and for other people, it's liquid handcuffs, right? And so you end up in this situation where you want to be able to serve both groups.
Really quick about addiction medicine and primary care, because we do see it right now. We're seeing a large expansion of buprenorphine availability, but there's some issues with that as well in terms of a workforce. So, some of the things that we were just speaking about earlier, you mentioned the waiver and the training that's needed, and both Scott and Helena mentioned this. So you can prescribe opioids, but you can't prescribe buprenorphine without going through a waiver. So we're working on that at the state level in medical education to sort of think about a workforce that could at least have some education in addiction medicine and know how to do this. And I think that's a really important issue. But in terms of the primary care, what we also see in my research is that those patients are being funneled towards certain providers that are willing to do addiction medicine in primary care. So again, for me, it circles back to the issue around the structural issue around medical education and normalizing and making sure that this is something that all physicians who are graduating understand how to treat and respond to people who have substance use or substance use disorder and how it's affecting their health, so that those folks are not still being sort of concentrated to certain providers within the clinic, and then I have MPs that I've interviewed who are not getting their DEA licenses because they don't want to prescribe opioids because they don't want to deal with the fear and adjudication. So there is sort of a workforce shrinkage and then this gap in primary care.
So we have time for one more comment or question. Yes, before I turn it over to Dean Catherine Lucy.
Hi, I'm Ziad Johan. I'm a first year medical student. There was something I noticed that was actually talked about a lot today, and I was curious about the framing of research that you had discussed previously, about how there was a racialization of research, specifically
Louder, please.
Specifically biomedical research, and I wanted to have more understanding, more framing about that, because I am planning to go into do a lot of biomedical research, and from my past previous experiences, I've seen that there are lack of recruitment of African Americans in studies and more diverse bodies in them. There are lack of framing and social aspects of specifically opioid addiction and those types of consequences as well. So I was just curious about how best to improve that, or just more framing about that, because that is a major body of work where that's where clinicians go into understand medicine.
May I tack on a second part to that question? It deals with racialization and the racialization of clinical spaces. I think we talked about it in terms of pharmaceuticals, but thinking through why policing looks different here on this campus compared to the San Francisco General, for instance. Thinking through where that comes from and the implications for learners.
So I would not like to be the only one commenting on this. Good. And I also wonder, not to put you on the spot, but Christina, you've thought a lot, I think, about the representation in medical research, and what that does with regard to the outcome of it. But I just wanted to quickly tell you about a theoretical framework that I'm often citing, which is standpoint theory, it comes out of philosophy of science, and it's a concept having to do with objectivity and the nature of objectivity that argues actually that in order to increase the objectivity and utility of our sciences, we do need to have a more representative scientific workforce, because the product that you produce is very much a function of who you are and your experiences. And so I certainly agree with what you're implying there. A colleague of mine in medical anthropology, Janelle Taylor, writes about medicine as the culture of no culture. And I think we're in a moment where, given the attention to the role of medicine and propagating the opioid crisis among many other problems, we as clinically active people, affiliated people, should be among the first to step forward and examine the culture of biomedicine itself, because it has been an implicitly white male cultural enterprise that operates by erasing its very own identity and foundations. And so that's one place to start, is by essentially exposing our own culture of medicine and advocating for just what you're suggesting. And then regarding law enforcement, a colleague of mine at Columbia, Carl Hart, whose work some of you may be familiar with, he talks often about law enforcement at Columbia University and its role in protecting the substance use of Columbia students. And that's actually accurate. You know, if you go through the city of New York, and the same probably happens here in San Francisco, from neighborhood to neighborhood, the role of law enforcement is either to protect you so that your drug use is safe, or to expose you to incarceration. And so I think the more that we attend to that, the better. And also, we as clinically affiliated people can bring it up as a health issue and bring a certain kind of symbolic capital to bear on that, get a certain kind of attention to that kind of inequality.
Yeah, just don't act like a cop. You're a doctor. That's all I'll say.
We published some data in social science and medicine earlier this year. We conducted some focus groups in Oakland, San Francisco, and Fresno, and they were all with women of color, and they were all with pregnant people. And 54 women talked to us, and about half of them had admitted to using some type of substance during pregnancy. And when we asked them at the end of our focus groups, you know, why would you participate in the study? Were you willing to talk to us? And they said, well, you know, you had flyers, you had all black women on the flyer, you were offering us food and childcare and transportation, and you know, we looked you up and it seemed like you were trustworthy, and so therefore we came to your focus group. So I think we need to rethink how we actually administer science and who actually conducts it, if you really want to be able to recruit, retain, and then co-partner with those individuals to be able to analyze your data and to be able to bring it back to them, and then to be able to get them to help you to understand and make meaning and sense of the data that you've actually collected, reminded by the fact that as taxpayers, they actually pay for you to be doing that work.
Right. Definitely. And I'd say that, you know, I just would echo some of these points. So definitely about the workforce, having a more diverse workforce creates better science. And I think science is evolving right now. And so having more people doing more community engaged research is necessary, and funders are starting to recognize that and require, you know, not just PCORI, but also NIH funded research is requiring kind of that people are thinking about this and engaging various subjects. But also in our university, I think that we're taking a big kind of huge step in trying to expand and make sure that all voices are heard and that all subjects are represented, all different types of people. And so I was trying to look it up on my phone, but I know Kirsten Bibbins-Domingo, who's the vice dean for population health and health equity, is having some session in a couple weeks or next week around kind of recruitment of various populations. Excuse me?
Yeah, with Dara Richardson, Hernan, all of us precision medicine cohort, community engagement physician Dara, what is her hyphenated last name? Richardson Heron will be here on November the 7th, talking through the recruitment strategy for the 1 million people that they want to participate in the precision medicine cohort.
Yeah, and then there's another session that I think they're having at Byers Hall that they're talking about it. Yeah, so anyway, a lot's happening here at UCSF in this regard.
So I want to now give the floor to Catherine Lucy, who's been taking a lot of notes. Maybe she's been taking notes on something else I don't know about.
Of course, thank you. I just want to first ask people to thank our panelists and our speakers again. I think they were also, I want to thank all of you who patiently stood and sat on the sides. Thanks for tolerating that we weren't able to get a bigger room, and we had a lot of RSVPs, and instead of turning people away, we thought this was a better thing to do. So for those of you who don't know me, I'm Catherine Lucy. I'm the Executive Vice Dean and Vice Dean for Education at the School of Medicine. This was just an amazing session, as these sessions always are. So thanks to my colleague Sharon, who's been a good and trusted friend in organizing these things. I just want to make a couple of observations. People have already commented about the strike, and then we've had an entire session on people with opioids. And it's impossible to live in this world without sort of recognizing that these are just two of the many forms of suffering that our patients in our communities are enduring these days. The Trump administration's HHS attack on transgender people this week, trying to define away people. You can't define away human beings. All you can do is basically legislate away our opportunities to keep them safe and to treat them as as us. And so I think that's another area that I think we really need to be vigilant about and pay attention to. When you think about your role as healer, all of you here have either committed to be a healer or are a healer. And our commitment as healer is to be on the side of human beings. It's our job to actually alleviate suffering. And it's our job to alleviate suffering in whatever form it comes, whether it's a form that we learned about as medical students or whether it's a form that we've had to learn about as faculty. And I hope that the message people are taking away today is one of responsibility for addressing all forms of human suffering, not just ones that are convenient to us or happen to fall into a nice, tidy box, and to work with others to actually address not only the individual person's suffering, but the broader suffering of our communities. I think that's so important. I want to make one observation that I think has really struck me as we've been thinking about the opioid epidemic and the lives it takes. And I think many of you know that we had a medical student last year die of a heroin overdose. Unbeknownst, no one knew that he had an addiction history. I also lost a nephew to heroin overdose this year. So this is an epidemic that you don't have to go very far to find somebody who has been touched by this epidemic, whether themselves suffering from substance use disorder or whether parents, daughters, lovers, friends who've lost a friend. There's an entity in medical education known as the hidden curriculum. And the hidden curriculum exists when there's a disconnect between the evidence of what we know to do and what we're taught to do is not modeled in what we do. That's the hidden curriculum. And I think the opioid epidemic and actually our global response as healthcare providers to all substance use disorders, the opioid being one of the most recent and very dramatic ones that we're dealing with, is just rife with the hidden curriculum. We know that there is evidence about how to treat pain and what types of pain respond to opioids. And yet, as Kelly said, we don't ask people to actually take special courses to treat opioids. We just ask them to get a license and they can write whatever they want, and in a very cavalier fashion, maybe unwittingly contributing to the launch of an opioid epidemic, opioid addiction problem, or the relapse of an opioid addiction problem. We know that the best care for people with substance use disorders who are interested in getting rid of their substance use disorder, or at least going into remission, requires a psychosocial and medical assisted treatment. And yet we don't do that. We actually demand abstinence before we are willing to engage in many other forms of medical care. And we actually don't use medically assisted treatment when in fact it would be tremendously life-saving for the individuals. There's so many other forms of the hidden curriculum. We know that substance use disorder is a biopsychosocial phenomena. It's a brain disorder, and yet we stigmatize people and expect them to actually show that they're worthy of the treatment that we think that they should have, not only for their substance use disorder, but often for other healthcare issues. We see this time and time again, people being rejected. And I would say we need to sort of reframe that in terms of our social contract to care for patients where they are with whatever condition they have. If you don't treat a chronic disease that you are capable of treating, that's neglect. And if you defy evidence in treating pain and use medications that actually can harm people, that's incompetence. And if you stigmatize your patients for conditions that they happen to have fallen prey to, whether it's diabetes or obesity or substance use disorder, that's violence. And we need to be thinking as clinicians of holding each other accountable for doing the hard work to make sure that we're prepared to treat our patients for whatever condition they bring to us, and to work with our colleagues if our expertise is not sufficient for that patient. The Vice Deans for Education in all the UC medical schools actually charged a task force last year to develop a University of California-wide approach to teaching about opioid use disorder. And I think Kelly is on that task force, and Scott has been involved, so is Dan Ciccarone, and many other people from the other medical schools. I do think that one of the they've actually done some amazing work and have a beautiful sort of outline of what should be done. And one of those is to enact a program to ensure that all graduates from the University of California medical schools have Suboxone waivers at the time that they graduate. But I think that's not sufficient, because it's not just about teaching you to prescribe another drug. It's actually about teaching you to be a participant in the treatment of substance use disorder. And if you take your Suboxone waiver course, never use it, which happens to a large percentage of people with Suboxone waivers, they just don't use it, it means that you are not actually preparing yourself to treat a chronic disease. There's no other chronic disease that we sort of say you don't have to learn to treat. No one gets to say, I don't think I'll treat diabetes or high blood pressure or osteoporosis. And so I think it's not, I think Scott's elective will be fantastic, but I also want you to understand that this is not as simple as taking an 8-hour course and getting a certificate that says you can get a Suboxone waiver once you have your own DEA license. It actually is a commitment that we have to make to use evidence-based treatment for the treatment of substance use disorder, and to be willing to continuously keep up with the evolving literature that Helena talked about on how best to eliminate this particular form of suffering for our patients. So I'm going to stop there. I found this to be an incredibly impactful evening. I have a ton of notes. I don't know what I'll do with them, but it was really helpful for me to listen to all of your incredibly wise commentary. People who have been here for a long time, Kelly and Christina and Monica and Scott and Helena. This is your second time back in this series, and we'd be happy to have you join our group too, so permanently. So with that, I'm going to close the evening, and thank you all.